Good afternoon, everybody. I'm going to present the preliminary findings of the study comparison of the performance of ultrasound versus chest X-ray in diagnosis of pulmonary tuberculosis in research-limited setting in Papua New Guinea. Papua New Guinea is a high-burden TB country with 42,000 new cases reported every year. Médecins Sans Frontières has been involved in TB care in the country since 2014. In collaboration with the Ministry of Health, MSF provides diagnosis and treatment to TB patients in Port Moresby, the capital city. Early diagnosis is a key element for TB control. Chest X-ray is one of the key tools for TB diagnosis, particularly when gene expert for bacteriological testing is not available or the results are negative. Access to X-ray is lacking in many peripheral of these high prevalence countries. In those contexts, MSF wonders whether using ultrasound could be an alternative useful tool for pulmonary TB diagnosis. The primary objective of this study is to assess the performance of lung ultrasound for TB diagnosis in patients with presumptive pulmonary TB, and to compare lung ultrasound findings associated with active pulmonary TB to radiological findings in the chest X-ray. The study was conducted in the MSF TB clinic in Gerehu General Hospital in Port Moresby, where MSF provides ambulatory TB care. This is a prospective diagnostic study which includes patients who come to MSF clinic looking for TB diagnosis and care. In the screening area, all patients are assessed, and those who report at least cough for 2 weeks were invited to the study. Those who consented, then they went through a first consultation, which included taking the medical history, the clinical evaluation, they got a chest X-ray done, and a lung ultrasound performed by the trained clinician. Based on all these elements, a treatment decision was taken, and the patients were categorized in confirmed TB, unconfirmed TB, or not TB. Both chest X-ray and lung ultrasound were interpreted on-site by the trained clinicians and remotely by ultrasound expert and radiology experts. The expert interpretation was the one used for the analysis presented. The information of the chest X-ray and lung ultrasound was collected systematically. The abnormalities were classified and the location was specified. To describe the location, we used 6 regions for the chest X-ray and 16 zones for the ultrasound. In the slide, we can see some of the findings that we consider that this was an active TB for each of the imaging techniques. At least the presence of one of them, we decided that the match was compatible with TB. And as you can notice, the findings to define active TB according to each technique is different. Between May 2022 to May 2023, 496 patients were enrolled. In the table, we can see some of the basic characteristics of these patients. They presented a median age of 30 years. They were mostly male, half of them had a non-TB contact, and a quarter of them reported to have TB in the past. 42% were diagnosed as pulmonary TB, and treatment was initiated. Most of them had the bacteriological confirmation with a gene expert positive in the sputum. 58% were considered as non-TB patients. We estimated the sensitivity and the specificity of the chest X-ray and lung ultrasound to diagnose TB according to the predefined findings for each imaging method that we showed in the previous slide. The analysis was done in 208 patients who had both ultrasound and chest X-ray review by experts. TB patients without a bacteriological confirmation were excluded from the analysis. The ultrasound had a sensitivity of 92%, which was similar to sensitivity found in the chest X-ray, and a specificity of 40%, which was lower than the chest X-ray. the sensitivity and specificity of the chest X-ray was 92% and 67% respectively. When we compare findings of suggested TB by the two imaging methods, the agreement was low, with a kappa coefficient of 0.37. This is probably due to the fact that each of the techniques detect different pathological findings. However, most of the patients with findings of suggestive TB in the chest X-ray had also findings on the TB in of TB in the ultrasound. To conclude, we can say that lung ultrasound has a high sensitivity to diagnose TB, which is comparable to chest X-ray. However, specificity is very limited and even lower than chest X-ray. Agreement between the two imaging tools was low, but lung ultrasound detected TB in most of the chest X-ray which detected TB. Lung ultrasound could be a potential tool for pulmonary TB diagnosis when chest X-ray is not available. And the next step for us is to look at the possible combinations of findings of the ultrasound to include the specificity and maintain sensitivity. I would like to thank to all the people who collaborate and did this study possible, and thanks for their attention.